hit record before that. Okay, so here is what's going on with diabetes complications. You have microvascular problems and micro and macro, so big vessels and small vessels that have problems. So micro vessels are the small ones, and for small vessel problems, we can have problems with your eye and have some retinopathy. It occurs in a couple of different ways, actually. It's not working. Okay. And I had to write it down because I don't want to screw things up and make you all mad at me again. So microaneurysms occur within the eyes that cause scarring, affecting vision. And then when that scarring occurs, the body starts to regenerate vessels, trying in an attempt to maintain perfusion to the eyes. And when it regenerates vessels, all of those vessels actually start to cloud your vision as well. Okay, so our mechanisms for regeneration actually cause some problems. Okay, so what's going on with this? When you have high blood sugar, you have a lot of problems with interstitial leakage between the vessels. And so with high pressure systems, when the blood pressure puts pressure against the vessels, it can cause leakage of lipids, and it can cause problems with accumulating lipids within the vessels. And we call that atherosclerosis. And so it would look like having fatty plaques within the vessels. And when those fatty plaques rupture, they cause aneurysms and cause problems here with the eye. That same kind of problem happens peripherally. It can happen in terms of both. Sorry, I feel distracted by my own work on the PowerPoint. Gotta stop. It can happen both with wound healing and with neuropathy. So because of the leakage of that lipids and causing atherosclerosis into the vessel walls, you can have damage to the nerve vessels there. It's going to leak into the vessels. It can leak out of the vessels and into the tissues surrounding it. And you can have neuropathies there. You can have problems with wound healing caused by the hyperglycemia. High blood sugar is a mechanism for bacterial growth. So if you have a lot of sugar available in the wound area, bacteria can grow there and thrive. And have a lot of problems with that. Vascular. When I say macrovascular, the large vessels, I'm worried about patients having coronary artery disease, stroke, heart attack, high blood pressure. Okay? I'm looking at those patients very carefully. And when I'm educating them about this, this is what I'm telling them. That if you exercise, if you lose weight, if you control your diet, you can help prevent a heart attack. You can help prevent a stroke. So you're not sugarcoating it with them. You're letting them know what they're actually doing. And that provides some education and some motivation. You don't want to scare tactic them, right? Like, you will, if you do not exercise, you will die. That doesn't work either, right? So you have to be tactful and understand your patient. 140/90. You guys are going to be surprised when you start seeing some of these diabetic patients having blood pressures of 180/100 as their normal. Okay? Very.
Are we as nurses allowed to, like, ask a patient to quit smoking or, like,
Absolutely.
try to lose weight and stuff?
Yes. Yeah. Yeah, so we'll consider that teaching, and so that's within your realm. That's a good question. Because it is confusing of where your role ends and the others begin. Okay, so back to blood pressures. What you can teach your patient is to monitor their blood pressures at home, teach them what the normals are, teach them when to go to the doctor about their blood pressures. And some of that has to do with trending their blood pressure. So if they are taking their blood pressure and it's always very high, it's difficult to say, well, you have to go see the doctor at X number of elevation, right? So then you might have to tell them symptoms. Even though we know hypertension is a silent killer, there are some symptoms that can occur when you have a hypertensive crisis, like blurred vision, headache, fatigue, fainting. So teach your patients about those. If you needed to teach your patient about sedentary lifestyle and how to resolve that, what would you teach them? What would you say to them? Exercise more? Okay. I'll exercise more. Is that specific? Okay, so that was more specific. Moderate physical activity, 150 minutes a week. Okay, so lifestyle changes, taking elevator and not taking the elevator instead of taking the stairs instead of the elevator. Parking far away from the store so you have to walk in. Okay, but you want to give them both real life examples they can incorporate without completely changing their life, something they'll adhere to, and something specific. So the 150 minutes a week is good. How do you know that you've reached moderate exercise?
Aerobic exercises.
So aerobic exercises, what? Lose weight. So we want their heart rate to increase. We want them to have a little bit of increased work of breathing, associated with exercise, but they should be able to say a whole sentence while they're exercising. So if they can only get a word in, like they're huffing and puffing, they're gone too far, and they're putting themselves at risk. So you, as the nurse, would teach them what to do. So the microvascular stuff, we're worried about the way the chronic sustained hyperglycemia is affecting the eyes and the kidneys and the skin and the nerves. So with retinopathy, we already talked about that, what's going on there. Because of the sustained levels of high blood sugars, the kidneys start taking a hit. It affects their glomerular filtration rate, and it starts to decline over time. It's not uncommon to have renal failure with diabetes. It's not uncommon to have neuropathy with diabetes due to the sustained high blood sugars. People with neuropathy could either feel paresthesias of their extremities, and paresthesias are numbness and tingling, or they might not feel anything in their extremities. And that's very dangerous if you can't feel anything, because you can become injured and not know it. And these guys have delayed wound healing. So if you injure yourself, you don't know it, and you have delayed wound healing, it's like this just perfect storm of bad events. I want to skip. We'll come back to it. So this is a picture of what can happen with neuropathy. I had a patient sort of similar to this one time. The patient had been sick for a couple of weeks, having fevers of unknown origin. And they had been in the hospital and been treated with antibiotic for fever of unknown origin and discharged home. And when the patient came back, when I was doing their admission assessment, I was the nurse that took the admission in. I did my full body assessment. With full body assessment, you're supposed to look at every centimeter of skin, right? That may have been missed on the first assessment because I found a penny embedded into the bottom of the man's foot. That was the cause of infection. He couldn't feel it because he had neuropathy. Apparently, no one looked at the bottom of his foot on previous admission because the penny was still there. So this patient had to have the penny excised, and it actually resulted in something very similar to this. And it takes a long time to heal, okay? So when you're doing your physical assessment, you look at every inch of skin, right? It's easy to overlook that. When you're in your clinical now, do you look at every inch of skin on your patient? No. You might now, right? Look between the toes of diabetics, because what happens with them, if moisture stays between their toes, it can cause fungus to grow and skin to break down. So every time you're assessing a diabetic patient, you should always look at their feet. Check between their toes, do some testing there to see what their feeling is, and document that. Teach them to look at their feet every day. Sometimes when you go to your doctor's office, you might see signs that say, if you're diabetic, remove your shoes. Has anybody seen those signs? Yeah, it's because we always want to look at your feet. We want to prevent this from happening. It's another example. In this case, what looks like happened is that the bone at the ball of his foot was pressing through and he couldn't feel it, and he just maybe walked without shoes or something and had this breakthrough. So that's another point for your patients. Your diabetic patient should never go barefoot. If they can't feel their feet, they need to have shoes on their feet with hard soles. Like flip-flops are no good. Crocs are no good. Real shoes. These shoes are no good. You have tennis shoes that lace up and have support. Periodontal disease can be a problem with patients with prolonged high blood sugars. Anybody understand the theory behind this? So if I have chronically, go ahead.
They don't have enough blood flow in their mouth?
That's actually a good guess, and that ends up being part of it later on, but initially it's something else. Yeah, so excess glucose in their system. Basically, their teeth are always being bathed in sugar, right? And then over time, we do have those microvascular complications, decreasing blood flow to the area, right? So you can teach your patients to see the dentist twice a year and try to prevent this. Patients who have teeth like this have a lot of pain and risk for infection. And if their gums become infected or they have a tooth abscess, it's very slow to heal. Oftentimes you have to pull their teeth. And in fact, if it were me, if this were my patient, I would advise them at this point to have all their teeth pulled and to get dentures to improve health. Because these teeth have been, are causing more problems than they're worth. We can't fix them at this point. So the best thing for the patient would probably be to choose to remove the teeth. And that's a big step for a patient. And so if you were to work with a patient who needed to have all of their teeth removed, you would have to look at their psychosocial needs. How would you feel if you had to have all your teeth removed? And you have to wait about 6 months or longer until your gums shrink up before you can get dentures. So then it becomes, body image. It becomes even a food issue. If you don't have teeth, can you eat? Do you lose weight? Is it a problem? So lots of things going on here for your patients. In July, most years I go down to the remote area medical clinic in Wise, Virginia. It's Southwest Virginia. It's the poorest part of the state. And we provide free medical care to thousands of patients over a weekend period of time. And the dental clinic is the biggest draw. And a lot of patients there will come in and have their teeth pulled 1 year and come back the next year and have their dentures made and go a whole year without teeth. And it's just so sad. It's hard to watch. Okay. Let's talk about hypoglycemic shock. So we talked about hypoglycemia, right? We know what that is, low blood sugar that causes weakness, confusion, all of those types of things. What makes it shocky is when it's prolonged low blood sugar, causing neurogenic and then cardiogenic shock. So what I mean by that is if it goes unnoticed and it gets so low that my brain stops having glucose to use for its machinery. You do know glucose is the only thing that crosses the blood-brain barrier to feed the brain, right? So if it's the only thing that actually crosses the blood-brain barrier to feed the brain and my blood glucose levels get too low, the muscles are asking for glucose, Fat cells are asking for glucose. They have to share it with the brain cells, right? And so these brain cells end up starving and dying. Excuse me. I have allergies for some reason this fall, so excuse my cough and stuff. Over time, yes, ma'am.
Does the brain not take priority? Is
The-
there a priority system when it comes to that?
Yeah, for this, there's not a priority system that works for that, but a feedback loop, it seems like it's the one place in the body where there's not a good feedback loop for that.
Why can't the brain swap the ketones?
They just can't cross the blood-brain barrier, the
If
ketones.
you don't eat for a while, like if you fast, you swap the ketones.
Well, first you break down glycogen, and you can use glycogen for your glucose first.
So
But-
they don't have glycogen in their system?
Yeah, so with this type of a system, they have so much insulin there that it's actually blocking the effect of the glycogen as well. So glycogen would break down to glucose for use. So much insulin on board, it's blocking all the receptors, or opening up all the receptors. Okay. Over time, you can be at risk for coma and death, right? So your job as the nurse is to know when hypoglycemia is likely and what you would do about it. Yes, ma'am. It depends on the patient, and it depends on how low their blood glucose is. A blood glucose of under 35 is considered very risky, so you want to catch them as soon as possible. I've seen patients with a blood sugar of 55, completely obtunded and making secretions from their mouth that they're unable to swallow. And I've also seen patients with a blood glucose of 30 talking to me. So there's no clear-cut answers. Assess your patient. Okay. If we give them glucose, they can return to a normal state. And then at that point, we want to try to adjust their insulin-glucose ratio to try to prevent this in the future.
So at clinical, there was a patient that was in Hypoglycemia shock
Okay.
yesterday.
So what did that look like?
She was very sick, very weak, could like barely open her eyes,
Okay.
barely sit up, like even in bed.
What was her glucose? Do you remember?
It was in the 40s when we
Mhm.
first did it, and then we did it again, and it got up to 60.
Okay.
And she, then she got better the next day.
So what did you do to fix her?
She wasn't my patient. I just got to.
You got to see some things?
I just got to.
So what, do you know what they did?
They
Was
let
she-
her sleep.
They let her sleep?
They gave her orange juice.
They gave her orange juice. Okay, so we put some glucose in there and monitor her, it sounds like. Okay, questions?
Do you have to give like pure glucose for this, or could you do something that like isn't pure?
So the question is, do you need pure glucose or can you give something else? And so in this case, since we're at an emergency situation, we want to give as much pure glucose, whether it's D50, whether it's glucagon or tablets in the mouth, something. But if we want to sustain glucose, that's when you want to add protein in there to their diet. Question?
So when someone's going into like a hypoglycemic shock, like is it easy or you don't? It's hard to tell if it's like hyper or hypo, wouldn't it be like?
Yeah,
with the
so
symptoms. So don't you always just give them, like if you were like a spectator and they were that? Because I worked as a lifeguard now. Like if someone was going into shock, you would give them sugar because like raising their sugar wouldn't do much. But like if they were hypoglycemic.
yeah, so this is a good point. Hypo and hyperglycemia can look very similar. So if you didn't have the ability to check a glucose level, you could, at baseline give glucose because it will fix it if it's high, if it's low glucose. And if it's high glucose causing the problem, you're not going to, 20 grams of glucose isn't going to take them over the edge, right? But in the hospital setting, you would have the ability to check a glucose pretty quickly. But if you were, at the mall and somebody passed out, give them glucose until a rescue squad gets there to figure out what the real problem is. Okay? Questions about this? Part. Diabetic ketoacidosis is next. This is a state of hyperglycemia. This typically happens to type 1 diabetics, but it could happen to type 2 diabetics. They used to teach us it only happened to type 1. Some of our type 2s are becoming more and more brittle, so to speak. Let's get back to insulin shock, right? I just want to, the name is insulin shock, so that seems like you all would get it, but just to be clear, people who are on insulin can go into insulin shock, right? People who are not on insulin, it's called a hypoglycemic episode, but maybe it's not called insulin shock, so to speak, okay? So I could, if I was in a chronic starvation state, I could have very low blood glucose levels, even though I'm not on insulin, and I could have a hypoglycemic episode, which you would give me glucose for. So just to clarify those things. Okay, so diabetic ketoacidosis. The name tells you a lot about it. It happens in diabetic patients, and they start producing ketones, and those ketones cause an acidosis in the body. So this is the one time where the patho matches the name, so it's nice. So it's actually a problem of decreased insulin, whether it's decreased insulin availability in the body, or they've decided not to take their insulin, exogenous insulin. It can happen from a couple of things. So another factor that goes into it is physiologic stress. With physiologic stress, you have increased production of glucose. So if you take a lack of insulin and physiologic stress of increased glucose, it just creates a kind of a chain of events. So without insulin in the body, the cells can't use the glucose. So there's lots of glucose floating around, and the cells are saying, oh, hey, glucose, come on in, but they can't come in. And the cells want to have some kind of energy. Since the cells can't use glucose for energy, they send a signal to the liver to say, we're really hungry out here, we can't get any glucose, give us some glycogen. So the liver sends out some glycogen stores. And you know what that does? It increases the glucose levels and even more. So serum glucose goes up higher. But there's still no insulin, so the body can't really use that glucose that came from the glycogen. So now the muscle cells are saying, this is getting ridiculous, I need something. That's when they start doing fat catabolism. They're breaking down fat into free fatty acids and using fat for its fuel source. Not a great fuel source, but it works in an emergency. So it's nice to have a backup system. The trouble is when you're using free fatty acids for fuel, when they start to break down in the body, they form free radicals and create oxidative stress. And oxidative stress with the production of ketones, so ketones are one of the byproducts of fat metabolism, they cause an acidic state within the body.
Can you say that last part again? So
About ketones?
it releases the free radicals.
The free radicals are the breakdown product of the fatty acids, and part of their breakdown is the ketone bodies, which actually cause an acidic environment in the pH of the body. Or the pH becomes acidic. So once the body becomes acidic, our buffer systems start taking over, and we start breathing quickly with those Kussmaul respirations in an attempt to try to resolve that. And if you smelled someone's breath when they're acidotic, their breath smells fruity from acetone dissipating. It smells, some people say it smells like juicy fruit gum. I think it smells like someone with alcohol intoxication. So it smells, and it smells like this sounds silly, a fruity alcohol intoxication. It's not like bourbon. When people drink bourbon, they don't smell like this. But when people drink like fruity mixed drinks, they smell like this. Yes? After the body.
Becomes acidic.
One of our counter-regulatory mechanisms takes over to buffer the pH, and that's the Kussmaul respirations, trying to blow off some of the acid. Okay, so on this chart, we kind of have walked down a couple of these aisles. We talked about decreased glucose transport into the cells and glycogenolysis. We've talked about lipolysis, breaking down of fat, and the breakdown of fat using those free fatty acids, and that when you use the free fatty acids, we release free radicals, and we also release ketone bodies, causing acidosis. Another thing that happens is ketone bodies are lost in urine. And so oftentimes when you're looking at a patient and their lab work, you're going to get a urinalysis and see ketones in their urinalysis. Sometimes you have patients who are on specific diets, like Atkins diet, a protein diet, where part of the diet is supposed to be having ketones in your urine, so that you're breaking down fat. That's part of that theory for that kind of a diet. Of course, dietitians aren't going to recommend that, right? That doesn't sound right. You don't want that in real life. Okay, so we have ketoacidosis and ketonuria. One of the things we need to talk about now is this one pathway of where we're going down hyperglycemia and glucoseuria. So remember, with glucoseuria, so with the kidneys, part of their job is to get rid of glucose that the cells aren't using and that's not going to storage. So they'll get rid of that through their threshold and they'll go out through the urine. Sometimes we'll have so much glucose passing through the kidneys that it spills out. And that's actually what they say. They say they're spilling glucose into their urine. So that's another thing we'll notice is glucose levels in their urine. And since the body's working really, really hard to try to normalize blood glucose any way it can, osmotic diuresis starts occurring. And osmotic diuresis occurs when the kidneys are filtering out the glucose and trying to rid the body of the glucose through the urine, producing lots and lots of urine. This becomes a problem because eventually the body becomes dehydrated and electrolytes become off balance. So the electrolytes that become off balance, which is the one electrolyte that really likes to follow water around? Sodium gets off balance. And then also potassium. Insulin helps to drive potassium into the cells for the cellular use. When insulin isn't available for use, serum potassium becomes high. The kidneys start to filter that out and we lose it through the urinary system. Sometimes you don't notice an electrolyte imbalance until you start rehydrating your patient. Okay, so we talked about polyuria, electrolyte imbalance, and dehydration. Polydipsia, of course, is going to happen because you're getting dehydrated. So patients will tell you they feel thirsty. The trouble is, what are some of the states that can precipitate diabetic ketoacidosis? What's some physiologic stress? How about infection? Infection can happen, and that's increasing my physiologic stress. Some infections might cause me to have vomiting and diarrhea. In that case, we don't really want patients to be drinking fluids by mouth, do we? We kind of want to give their gut some rest. So polyuria might be a sign that you see in your patients. In that case, what would be a nursing intervention you could do to somebody who felt very thirsty but couldn't drink fluids? Ice chips, IV fluids. We have these mouth swabs. We can put mouth swabs in water, and they're the green spongy things. Have you seen them? So green spongy things you put in water and get their mouth wet. It helps. We used to have these things called lemon glycerin swabs that we could swab out the inside of their mouth that would coat it with glycerin for moisture. Apparently they taste horrific. You've used those? Okay. How did your patient do with those?
She didn't really vocalize how she couldn't.
Okay.
She's in a lot of pain.
A lot of
She
pain.
wouldn't eat, so
Keeping her mouth moist.
no. They were like 3 or 4 packs sitting on her dresser.
Okay, good.
I
Good.
was like, oh, I wonder what those are
Now you found out.
There you go.
Okay, so how do you treat diabetic ketoacidosis? What's the primary problem? we don't have insulin, so we'd give insulin. We're dehydrated, so we give fluids, IV fluids of usually normal saline. Our electrolytes are off balance, so we give electrolyte replacement, potassium and sodium. And our pH is low. So our pH buffer system's not quite working, so sometimes we give sodium bicarbonate to try to buffer out their their pH level. Okay? So is all that kind of making sense as a process? Yeah? Okay.